But I still have a concern if somebody know what is the solution for this posterior synechial. I know Klaus Eckert, he has special lenses and he do posterior capsule, but for me, I didn't do it. Any suggestion for this posterior synechial?
No, I've seen it rarely. Well, you know, I tend to have, the rexus shouldn't be too large that you don't have that it doesn't flip, especially when you have an air bubble inside the vitreous cavity by the end of surgery. And I tend to have my tunnel a little bit longer because it's just for the stability. But you don't have to suture it, and even I do usually in retinal detachment surgery where you have to combine it really a very heavy indentation, and in my hands the lens is really stable after phacoemulsification, and you don't have really to manipulate, you can really manipulate from the globe and there's no movement of the lens afterwards.
Dr. Kakan, you have a quick comment?
I have a quick comment. I tend to disagree about the small capsule rexis for vitrectomy and phaco. Because it depends on the choice of intraocular lens. If you use a multi-piece IOL, then you don't need a small rexis. And believe me, your small rexis doesn't stabilize your intraocular lens. It's rather induced posterior synecdoche with the more induction of the posterior synecdoche from the iris with the capsule rather with the iris with the lens. So you are, but by doing the small rexis, you are intending to prevent it, but you are enhancing this one. So it doesn't prevent your posterior synecdoche. Get a big rexis, 5 or 5.5, you will have a less synecdoche. Use multi-piece IOL, you will have a good stability. I mean, doing small rexis is of no logic to have a good stability. And keeping the air in the anterior chamber, I don't know how it will help.
Yeah, thank you, Kakan. Maybe can we have a quick point here? Okay, we'll get back to you, Dr. Hassan. But can we make the comments quick so we can move on? Dr. Saad, can you connect?
Rexis is 5 millimeter, not below 5. So to cover whole of the optic all around, not to have any place which is not covered by the rexis. Yeah. That's the meaning of small rexis, not smaller than that, not 4, for example. And long tunnel prevents, as you mentioned, and I think I agree totally about that. And you usually do not need to suture any of these lenses. I tend to disagree about whether it is 3-piece or 1-piece. Even 1-piece, it's very stable, as long as you put it right and you cover the whole optic with the rexis.
So one point regarding the post-op inflammation and posterior synechial formation. I get to use the intracameral dexamethasone in combined procedures, so this is decrease the risk of inflammation post-operatively and also decrease the risk of posterior synechiae.
Okay, we have a quick comment here, Dr. Hassan, right? Do you want to say something?
So as a pearl for preventing posterior synechiae, I do usually at the end of my combined cases inferior reductectomy with the vitrector, and that have solved major issues for me in reducing the pupillary block issues that you may face, and also posterior synechiae. And I usually suture all my incisions with the 10-0 sutures, and that have helped keep the anterior chamber stable. And I wouldn't probably use air in the AC because that kind of maybe dislodges the lens also as well.
Thank you so much. That's a great question. I think all are debatable, but small rexes, you want to keep the AC deep. Air in the AC is good in those 3 that works for them. I use it, and you want to make sure you have a long tunnel and keep the AC deep. Well, thank you so much. We'll move to Dr. Saad Wahib about zipper syndrome and precursor to GRT, GRD. Thank you, Dr. Wahib.
Thanks. Thank you, Ahmed, for the great invitation. And I'm sorry I came a little bit late. I couldn't join your esteemed panel. I came in and I went into the wrong room. So I was sitting in the cornea room, and everybody was looking at me, and they said, "What you doing here?" So I knew I was in the wrong room. Okay, so without further ado, let me start with this rare complication that we see sometimes preceding cataract surgery. I'll start with the case. This is a 35-year-old male, healthy, who came to see me. He used to be a moderate myope. He underwent uneventful refractive lens removal in both eyes, and he was doing pretty well, very good vision until he came 6 months down the road after the surgery with a macula on RD. I saw him and I told him that you're going to have to go for surgery. So I'm just going to start the video to show you here the case. Initially, what I've noticed when I was doing this case, and I've seen a couple of these patients, they have a very opacified vitreous, and the vitreous base is posteriorly inserted. That doesn't look like the usual vitreous base that we usually see, that is usually more peripheral. And with this, you notice with the video that they have a run of holes that are along the same meridian, and these are multiple holes, and they're all tractional holes. You can see here there is actually both in attached and detached retina, and they are lined along the same line. And sometimes because the detachment is very bullous, I actually have to use the light pipe to prevent the retina from coming. But what I have noticed in these patients is that these are very specific cases where you see these holes lined. First of all, they're posterior, they're along the same meridian, and the vitreous base is looking abnormal. And the holes are present both in attached and detached retina. So the surgery was concluded in the usual fashion. For the sake of time, I'm just going to pass into the next slide. I put silicone. He looked well. And again, you can see in post-silicone removal pictures how the holes are multiple on the side. And this is something that I've seen in these patients. There's a group of patients. A typical patient is usually a young, male, myopic. Okay, and these, on examination, as I said, they have abnormal vitreous. The vitreous is really abnormal, opacified, and these usually they have multiple holes, again, along the same meridian. You see these holes in usually both eyes. And I think once you see these patients, you have to worry, because the problem is these holes can coalesce with each other in a zipper fashion, and they will be the precursor of a giant retinal tear. I did not describe this. I was not the first one to see it. I think our great friend here, Dr. Athanasis, has seen this and described it before me. But I think it is something that we need to be very careful of. Now, if you look at the anatomy, the ora serrata, the vitreous base straddles the ora serrata 2 to 3 millimeter, and it's usually very peripheral. In these patients, the vitreous base is abnormal. It moves posterior, and it's actually wider. And I think it's very important to recognize this abnormality, because I think if he was recognized prior, maybe he would have been lasered. So the take-home message for me here is that, be careful of these young myopic patients, male specifically. You have to do a good peripheral exam, and what I do, I usually document my exam with fundus photography, preferably the Optos. I discuss with them all available options and the possible rate of complication. 1% of all phaco will develop retinal detachment, so I think they need to be aware of that. If I see the problem, I will pre-treat it with laser, and I think this is a condition that we need to be aware of, specifically retina surgeons. They are not common, but you will see them definitely. So I think this is you on the right side with the big eyes, and that is zipper. So please, please be careful. Thank you. Sure. Why don't you come and do just talk about zipper.
Okay. We can have a discussion on drop nucleus. Oh, here you go. Wow. We've made it.
Well, I call it zipper because it's also in the attached retina. And if you don't care about it and you just fix the tear, you'll find yourself in trouble. And there's no way to remove the posterior base completely. There's no way. It's so much embedded. But I'm going from one to the other. Well, we had some surprises by doing that. First of all, I would like to invite you, because we're starting a new mission. This is to teach people how to face troubles, and it's done in Thessaloniki every year in July. So I'm asking the professors to come and teach, and everybody to come and teach, because nobody's a student anymore. Everybody knows everything through the internet. So we do this thing in Thessaloniki, so feel free to come the first week of July. And this is the result of what I call phishing. Phishing means that some surgeon decided to have a dropped nucleus or some complications, and he decided to put some trocars to do a posterior. And he put the trocars a little bit funny way behind. How can I start the video, please? Can you start the video? Okay, this is how I get into it. Another thing with Carson that we decide is we always use a chandelier light in dropped nucleus. This is the #1 indication for chandelier lights, because you have two hands. And the other change we made is that we're using the right hand to have the forceps and the left hand to the vitrectomy. Here, what we saw a retinal detachment, but where is the nucleus? There's no nucleus. It's an eye. He promised me he dropped the nucleus, and I just saw a retinal detachment. And then I saw this. Has a huge tear at the side of the trocar, and trying to look for the nucleus, I started, I don't know if I can have this, I started to check out to find out where is the nucleus. And then I saw I have to use a vacuum, 650 vacuum with a flute needle, to go inside searching for the nucleus. And this is the birth of a nucleus. And look what's going on. The hole, the tear, it's much smaller than the nucleus due to the elasticity. Look at that. And I think it was the first time that I've seen that. I don't know, a lot of people have seen that. And this is how we started the vacuum and how to do that. Now I'm stuck because I need to remove it, and I have a huge hole and I have a floating retina, and it's very difficult to use any tricks that I know of. And the trick that I know of is you never touch anything that's sitting on the surface of the retina. If you want to cut something, you have to go away from the surface. And you don't catch things while they are sitting on the surface, because you actually put the